Introduction. Welcome, aspiring neurologists and medical students, to today's lecture on the complex and fascinating field of neurology. In this detailed script, we will delve into the intricacies of the genetic disorder known as Becker muscular dystrophy, BMD. BMD is a progressive muscle wasting disease caused by mutations in the dystrophin gene, and understanding its genetics, pathophysiology, clinical presentation, and management is crucial for providing optimal care to affected individuals. So, let us embark on this educational journey and explore the various aspects of BMD. Becker muscular dystrophy is an X-linked recessive disorder caused by mutations in the dystrophin gene located on the X chromosome. Mutations in this gene can result in a deficiency or abnormality of the dystrophin protein, leading to muscle degeneration. The dystrophin gene is one of the largest known genes, composed of 79 exons spanning approximately 2.4 million base pairs. Different types of mutations, including deletions, duplications, point mutations, and small insertions or deletions, can disrupt the reading frame or affect the functional domains of the dystrophin protein. Genetic testing, such as multiplex ligation-dependent probe amplification, MLPA, or next-generation sequencing, NGS, plays a crucial role in diagnosing BMD and identifying specific mutations. Understanding the genetic basis of BMD not only aids in diagnosis but also provides a foundation for exploring potential therapeutic targets. Dystrophin, a large cytoskeletal protein, plays a critical role in maintaining the structural integrity of muscle fibers. It is predominantly expressed in skeletal, cardiac, and smooth muscles, as well as in the brain. The dystrophin protein has several functional domains, including an N-terminal actin binding domain, a central rod domain composed of spectrin-like repeats, and a C-terminal domain responsible for linking dystrophin to the dystrophin-associated glycoprotein complex, DGC, on the sarcolemma. The DGC plays a crucial role in stabilizing the sarcolemma during muscle contraction, protecting the muscle fibers from damage. It also helps transmit the force generated by the sarcomeres to the extracellular matrix. Mutations in the dystrophin gene disrupt the normal structure and function of this protein, compromising the integrity of the muscle membrane and leading to progressive muscle weakness and degeneration. The pathophysiology of BMD involves a cascade of events resulting from the absence or abnormality of dystrophin protein. The disruption of the DGC leads to increased susceptibility of muscle fibers to mechanical stress, causing repeated cycles of damage and repair. Inadequate repair and regeneration of damaged muscle fibers ultimately lead to fibrosis and fatty infiltration, contributing to a decline in muscle function. Additionally, the absence of dystrophin alters signaling pathways involved in muscle growth, inflammation, and oxidative stress. These molecular derangements further exacerbate muscle degeneration and contribute to the progressive course of BMD. Understanding the pathophysiological mechanisms of BMD aids in the development of targeted therapeutic interventions aimed at slowing disease progression. Becker muscular dystrophy exhibits considerable clinical variability, with a spectrum of presentations ranging from mild to severe. Typically, the initial symptoms manifest during childhood or adolescence, although delayed onset cases have been reported. Muscle weakness and fatigue, especially in the proximal muscles, are the hallmark features of BMD. However, the pattern and extent of muscle involvement can vary significantly among individuals. Patients with BMD may exhibit a waddling gait, difficulty climbing stairs or rising from the floor, and muscle cramps. As the disease progresses, individuals may experience respiratory muscle weakness, cardiomyopathy, contractures, and scoliosis. The rate of disease progression is generally slower compared to Duchenne muscular dystrophy, another dystrophinopathy. The phenotypic variability in BMD can be attributed to various factors, including the type and location of the dystrophin gene mutations, the production of truncated but partially functional dystrophin proteins, differences in the compensatory mechanisms within muscle cells, and the presence of modifier genes. Diagnosing BMD involves a comprehensive approach encompassing clinical evaluation, genetic testing, and ancillary investigations. The clinical assessment includes a detailed history, physical examination, and evaluation of muscle strength using standardized scales such as the Manual Muscle Testing, MMT, or the Medical Research Council, MRC, scale. Genetic testing is instrumental in confirming the diagnosis of BMD. Techniques like MLPA and NGS can identify large deletions or duplications, point mutations, and small insertions or deletions within the dystrophin gene. Other tests, such as muscle biopsy, can provide supporting evidence by demonstrating dystrophin deficiency or abnormality. Ancillary investigations such as electromyography, EMG, and muscle imaging using techniques like magnetic resonance imaging, MRI, may be utilized to assess muscle involvement, disease progression, and response to therapies. The accurate and timely diagnosis of BMD enables appropriate management strategies to be initiated promptly. Distinguishing BMD from other muscular dystrophies and neuromuscular disorders can be challenging due to overlapping clinical and pathological features. Duchenne muscular dystrophy, DMD, the most common dystrophinopathy, often presents with a similar clinical phenotype but typically has an earlier onset and a more rapid progression than BMD. Muscle biopsy findings, including dystrophin immunohistochemistry and Western blot analysis, can aid in differentiating BMD from other muscular dystrophies associated with dystrophin deficiency. Genetic testing, specifically identifying the causative mutations, plays a vital role in establishing an accurate diagnosis and guiding appropriate medical management. Other neuromuscular disorders such as limb-girdle muscular dystrophies, congenital muscular dystrophies, and metabolic myopathies should also be considered during the differential diagnosis process. A comprehensive evaluation incorporating clinical, pathological, and genetic information is essential for achieving a definitive diagnosis. Cardiac involvement is a significant complication of BMD and contributes to morbidity and mortality in affected individuals. The dystrophin protein is expressed in cardiac muscle, and its deficiency or abnormality leads to progressive cardiomyopathy. The characteristic features include left ventricular dilation, systolic dysfunction, and arrhythmias, predominantly affecting the conduction system. Regular monitoring of cardiac function through clinical assessments, electrocardiography, ECG, echocardiography, and cardiac magnetic resonance imaging, MRI, is crucial in identifying cardiac involvement and initiating appropriate management strategies. Cardiac medications, such as angiotensin-converting enzyme, ACE, inhibitors and beta blockers, can help mitigate the progression of cardiomyopathy and prolong survival. The management of BMD requires a multidisciplinary approach involving neurologists, rehabilitation specialists, cardiologists, pulmonologists, genetic counselors, and allied healthcare professionals. Individualized management plans should address the specific needs and challenges experienced by patients and their families. Physical and occupational therapy play a crucial role in maintaining muscle function and preventing contractures. Assistive devices, such as braces, can aid in ambulation and improve quality of life. Regular cardiac evaluations, including monitoring of cardiac rhythm and function, help identify and manage cardiac complications. Pulmonary function testing and intervention, including respiratory support if needed, ensure optimal respiratory function. Genetic counseling provides vital information about disease inheritance, family planning options, and the potential risk to other family members. Psychological support and social services are essential components in managing the emotional and practical aspects of living with BMD. Genetic counseling plays a crucial role in families affected by BMD. Genetic counselors provide information about the inheritance pattern, recurrence risks, and choices available for family planning. By assessing the specific mutation identified in the affected individual, they can estimate the likelihood of other family members being carriers or at risk of developing BMD. The genetic counselor also provides emotional support and facilitates communication within families, assists with decision-making regarding prenatal testing, and offers access to resources such as support groups and advocacy organizations. Ongoing genetic counseling is essential, considering the evolving understanding of BMD genetics and the potential implications for emerging therapies. Pharmacological interventions in BMD aim to alleviate symptoms, slow disease progression, and improve quality of life. Corticosteroids, such as prednisone and deflazacort, have shown efficacy in reducing muscle inflammation, improving muscle strength, and delaying disease progression. However, their long-term use is associated with side effects that need careful monitoring. Emerging therapies, such as exon-skipping agents and gene therapies, offer promising avenues for targeted treatment of BMD. Exon-skipping compounds, like eteplirsen, aim to restore the reading frame of the dystrophin gene, allowing the production of partially functional dystrophin protein. Gene therapy approaches, including microdystrophin gene transfer and CRISPR/Cas9 mediated editing, hold immense potential for addressing the underlying genetic defect in BMD. Complications arising from BMD impact various organ systems and contribute to the morbidity associated with the disease. Respiratory complications, such as ineffective cough, recurrent chest infections, and respiratory failure, necessitate careful monitoring of pulmonary function and the timely initiation of interventions such as non-invasive ventilation or tracheostomy. Scoliosis, resulting from progressive muscle weakness and imbalances, requires regular spinal assessments and, if necessary, orthopedic intervention. Nutritional support is essential to prevent weight loss, optimize growth, and maintain adequate energy levels. Psychosocial complications, including depression, anxiety, and social isolation, warrant appropriate counseling and support services. The prognosis of individuals with BMD has improved significantly over the years due to advances in medical care and supportive therapies. The course of the disease varies based on individual factors, including the mutation type, muscle function, and comorbidities. Regular medical follow-up, adherence to therapy, and early intervention for complications are crucial in optimizing outcomes. Life expectancy in BMD is generally reduced compared to the general population, mainly due to cardiac and respiratory complications. However, improvements in cardiac management, ventilatory support, and emerging therapies hold the promise of further extending survival and enhancing quality of life for individuals with BMD. In conclusion, Becker muscular dystrophy is a complex genetic disorder with diverse clinical manifestations and significant implications for affected individuals and their families. Understanding the genetics, pathophysiology, clinical presentation, diagnosis, management, and prognosis of BMD is essential for providing comprehensive care. As future neurologists, it is imperative that you strive to stay updated with the latest advancements in research and therapies targeting BMD. Your knowledge, compassion, and dedication can make a substantial difference in the lives of those affected by this challenging condition.